You are all welcome, dear participants, to chat with me, and I will try to answer all your questions. So I decided to start with some theory because, first of all, you need to know what myopic traction maculopathy is and how to recognize the correct stage to implant the buckle. I have published this staging system 3 years ago, and this is to make your life easier, to make MTM easier to understand. So don't be scared from this table, because this table tells you exactly everything you need to know on MTM. It shows you the evolution from top to bottom or from left to right. It gives you the nomenclature, the stages. So, and it offers you also in blue under each stage, you can read the average time that is taken to evolve from one stage to the next. So you can also offer prognostic information to your patient. It has been internationally validated. And in summary, to select the stage, you look at your OCT with MTM, look inside the macula and select 1, 2, 3, or 4. And then you look into the fovea and select A, B, or C. So if you look into the macula, you can choose between stage 1, schisis in the inner layer or inner outer. Stage 2 is the schisis in the deeper outer layer. Stage 3 is the stage where the foveal detachments appear. There is a combination of schisis and detachment. In stage 4, there is a total detachment. And if you look in the retina, there is no schisis inside because it's been released by the detachment. Now, look at the fovea, the inner fovea. For each one of the 4 stages, in stage A, the fovea is intact. In stage B, there is a tangential traction that leads to a lamellar inner macular hole. In stage C, there is a full thickness macular hole. So basically, as I said, you look at the macula, select 1, 2, or 3, or 4. You look at the inner fovea and select A, B, or C. And let's start. I would like to hear your voices here and ask you, which stage is this? If you look in the macula, this is stage 1. There is a very mild schisis. You look in the fovea and there is a full thickness macular hole. So this is stage 1C. Another example, you look at the macula, and here there is not so much contrast, but there is retina inside here with the deep schisis. So this is stage 2, because there is no detachment. The fovea is intact, so this is stage 2A. Look here, the macula is completely detached, but the inner fovea is intact. So this is stage 4A. Here, there is a combination of schisis and detachment, if you look in the macula. And then if you look in the fovea, there is a full thickness macular hole. So this is stage 3C. And hold on. Okay. This is a combination of schisis in the inner and outer layer, but the fovea is intact. So you see an evolution because the staging system is dynamic. This is an evolving disease. You can see stages in between. So this is between stage 1A and 2A. And again, here the macula is totally detached, but the fovea is intact. So this is stage 4A. What is a lamellar outer macular hole? This is a little more difficult, but I would like in this course to explain. Please look at the outer layer and look at the photoreceptors layer. This is the first patient where I learn what an outer lamellar macular hole is. I could see this foveal detachment, and in the left, you can see this image, which is so whitish. I was expecting what? The first thing you think about is macular atrophy. So I was expecting in the autofluorescence to see all black. Instead, it was normal. And in the color fundus, you would expect to see a yellow area. Instead, the fovea was normal. So I was thinking, what is this? This is not atrophy of the RPE. In fact, after the operation, I could obtain a complete disappearance of that whitish area in the infrared image. So I learned that this is the outer lamellar macular hole. It is an interruption into the photoreceptors layer that gives you a backscattering in the fovea in the scleral plane and can be reversed by the surgery. This is the outer lamellar macular hole. So an interruption in the photoreceptors layer with backscattering beneath. And this is a combination of outer lamellar macular hole, you see the backscattering, and the inner lamellar macular hole, which is an interruption in the inner fovea. So how to treat MTM? This is the focus of the course today. These are some of my publications on the subject. You can find them in the literature. In this one in particular, I have studied a customized treatment per stage. So this is the same table that I've been showing. In red, you see that for each stage, I have offered a guideline of management customized per stage, because in stage 1A and in stage 2A, I advise to do nothing, just observation, for two reasons. Because if you see in green, the average visual acuity is still good in this patient because the photoreceptors are attached, intact. And also, you look in blue, the time taken to evolve from one stage to the next is long, is a slowly progressing disease. So it's better to do nothing because, of course, we can have some complications from surgery. Instead, in stage 3A, 3 and 4A, my advice, you see in red MB, that stands for macular buckle. This is the perfect indication to start with the buckle only. No vitrectomy, only buckle. And I will show you how, because you reattach the fovea and stop the progression of the disease forever. Let's go to the second column. In stage 1B, I wrote pars plana vitrectomy, but only if symptomatic. So basically, this patient has only a lamellar macular hole. It is very controversial whether to operate or not a lamellar macular hole, especially in myopic eye, because you run the risk of inducing yourself a iatrogenic full thickness macular hole. So my advice is to do nothing and to do vitrectomy with the flap only if the patient is really getting worse and symptomatic. But in stage 2B, 3B, and 4B, again, please place only a macular buckle. Only a macular buckle for the first surgery. Because if you reverse the schisis and detachment, then the visual acuity can improve even if they have a lamellar macular hole. No need to touch the fovea. It's only in stage C, where there is a full thickness macular hole, that you need an ILM flap, because remember, the macular buckle can reattach the fovea, can reduce the schisis, eliminate the schisis, but cannot close a macular hole. If you want to fully close a macular hole, you have to go from the inside, and that is the indication for vitrectomy and maneuvers on the hole. So this is in summary what I said. The holes need an ILM flap or another maneuver to close from the inside. The schisis detachment need a buckle. So this is an example of an ILM flap, which is very difficult in these cases because you have no contrast, but it's the only way to close those holes. Instead, if you look in OCT like this, you've learned now that this is stage 3A O, because there is also an outer lamellar macular hole. And this is a stage 4A. Provocatively, I wrote that this is a scleral detachment, because if you think about the sclera detaching from the macula, then a scleral approach is even more appropriate. But anyhow, try and imagine intuitively what might happen to this retina if you push it against the sclera from the inside. What might happen? What could be the result? So this patient, not by me, was operated with a vitrectomy, and this is the classic approach everywhere in the world at the moment for a case like this. And is this considered a success? Do you think this a success because the retina is attached? Yes, it is attached, but this is not a success because the patient cannot see. There is a full thickness macular hole with a macular atrophy. He had glaucoma because the colleague used the silicone oil. And so this is not a success. We need to treat the detachment with the buckle. These are my cases. I have operated much more than 350, but I don't have available data, at least now, for everyone. But I'm collecting more and more data over a very long follow-up period. And please allow me to be sensational with you. Allow me to write 100% anatomical success. What do I mean? As you can read, I wrote complete or partial macular attachment. It means that if you have a macular detachment or macular schisis and you place a bacular buckle, you will always attach the macula. You will always reverse it. It's mathematical. Of course, it has to be perfect. It has to be well-centered with no complication. But if you place it under the macula, you will reattach it. The functional success is limited, of course, by the amount of atrophy, or if the patient has amblyopia, anterior media, many different factors. But the anatomical success is guaranteed. And I can show you some example here of pre-op. You see, I checked this patient 1 month preoperatively, and then in 1 month she had already got worse. This is a stage 3C. And this is after surgery. You see the macula is attached and she has a very significant improvement in vision. So my message to you is that this patient can have enormous visual benefit as long as the choroid is not atrophic in the macula. So look at this OCT. This is a huge detachment with a full thickness macular hole. Don't call it myopic macular hole detachment. Call it stage 4C. This is after surgery. I did a combination of macular buckle, ILM, flap, and you see a very nice horizontal macula with a closed hole. Visual acuity is very significant. Look on top here. There is on microperimetry a huge scotoma. She has a stage 3C because there is a combination of schisis and detachment with a full thickness macular hole. And underneath, you can see the result after surgery, the disappearance of the scotoma. There is no atrophy in the macula, a very nice flat macula with a closed hole. You can see 7/10, 7/10. These are patients that you can make very, very happy. So that's why I think that buckle is better than vitrectomy alone for the schisis and detachment, because I have seen many, many cases that, and I always compare the eyes. For instance, this eye has been operated multiple times, not by me because I don't do this anymore. First, it's been operated with a vitrectomy and gas, but then she had a relapse. It was originally a stage 3A. So the macula redetached and she was operated with vitrectomy and oil, and then silicone oil removal, and then heavy silicone oil. So this is an example of how an eye can end with no vision and glaucoma. She comes for the other eye with a very good choroid and this traction. This is stage 3A with an extra macular pre-retinal formation. I did only macular buckle to treat the macula, and this is the result just 6 months after surgery. She has a great improvement in vision. You can still see the extramacular traction, but I don't need to remove it because the macula is okay. And you can choose to do vitrectomy if you need to remove the epiretinal proliferation in a second step when the macula is attached. Aesthetically, some colleagues ask me, how does an eye appear after buckle? So here you can see in one eye the aesthetic result of the buckle, and in the other eye, the very bad eye appearance after 5 surgeries with glaucoma, with vitrectomy and silicone oil. Another example, in this eye, she was operated only in the classic way with vitrectomy multiple times. This patient comes for the other eye with this detachment. This is after buckle only. This is a very nice, and I always like to show it because this is the same patient, 43 years old male, with the same stage of MTM in both eyes, a detachment of the macula with an intact fovea. So he receives buckle in one eye from me, but then he, since I'm operating in private now, he could not afford it and decided to do to a different hospital for the other eye. So this is the result. In the eye where he was operated with the buckle, he had the resolution of the case with a great improvement in vision, while he ended up in a full detachment with the full thickness macular hole after vitrectomy. So I operated the second eye too, and now he's okay in that eye as well. And I want to show you my best case just to tell you that it is possible to gain a huge amount of vision. He had originally a macular detachment in stage 3AO, axial length 32.8 with 20.5 diopters of myopia. You can see on the right the result after macular buckle. I also removed the cataract and implanted the multifocal IOL. He can see 20/20 far and near uncorrected. So this is what I define real success in MTM surgery. And so these are the reasons that leads me to advise you to use a macular buckle in stage 3A and B as the first and only procedure, because the results are great and the complications you will see now is fairly easy. The complications are there, but they are acceptable. You can manage them, and it helps you to avoid silicone oil. Okay, so I am done with the first talk. Reyes, I don't know if you have seen any questions. Otherwise, I will move on to the surgical talk.
Yes, go ahead, please. Thank you.
So let's go into the surgical part. I want to show you what happened in the past. For myopic traction maculopathy was originally treated with from the external side. So it started in 1930, basically 1 century ago, with implant of fascia lata behind the macula. And then the first attempt of macular buckle in the 50s. And then all different sorts of episcleral surgery. And of course, in the 1980, vitrectomy starts. And so from then, we see in the literature basically vitrectomy against or with the buccal most of the time. But if you see, macular buccal basically recurs periodically, and this is due to the fact that vitrectomy unfortunately did not lead to spectacular results in this pathology. I started to speak about macular buccal for the first time in 2009. I was in Amsterdam at the HITAM meeting, and it was actually nobody at the time was speaking about macular buccal in the meetings. Nobody, I can tell you. And after that, I started to speak basically in almost every meeting, and a new series of literature came out. What is a macular buccal? In summary, a macular buccal is a medical device that shortens the eye, that shortens the axial length at the posterior fold. It has a head, which is the part buckling the macula, and the arm, because I started in 2007 to think about a buccal that could be sutured anteriorly and not posteriorly. In fact, the first buckles were sponges that were sutured behind the macula. And this is why everybody abandoned the technique, because it was too difficult and it was too dangerous. You can imagine how it was possible to, you had to cut the muscle, turn the eye, place the sponge behind the macula and suture there, with the high risk of penetrating the eye and creating major complications. So the whole idea, I picked up the surgery in with this type of approach, and I changed, and I said, we should not place a buccal behind the macula. We should place a buccal that we can suture anteriorly. And then you can find also different types of proposal in the literature, which remained isolated, and unfortunately, they never had luck. This is the very first buccal that I implanted. I basically used a sponge, the 507 sponge that we had for peripheral surgery. And I inserted, as you have seen, this is a thread in titanium that I found in my OR, borrowed from instrumentation that we use for eye surgery. But the idea was to create an L-shaped buccal that could be implanted into the superotemporal quadrant, and most of all, that could be sutured anteriorly. This was the whole idea. You see here the buckling effect in the macula, and this was the start. So then I tried different types of creating an L-shaped buccal with a titanium and sponge, and I've been using this model until recently with the idea to suture anteriorly. As I said, I presented it in 2009, and for a long time, until 4 years ago, this is how I used to make a buccal in the OR with this ring titanium stent. I added the lights to use transillumination. It takes 5 minutes to do it in the OR, but this is totally off-label. So I used to insert through the superotemporal quadrant after making a paracentesis. Here you see the insertion of the buccal in the superotemporal quadrant. And I used to watch the position through a panoramic viewing system, and then I used to remove the system and suture the buccal close to the insertion of the muscles, like here, with the mattress suture. So I can tell you that I found the technique easy, but nobody found it easy, so nobody was doing so. And so in the end, I decided to switch to a commercially available product. It was the AJL product, this one in the picture. And so I decided to implement and develop and study the potential of this device in the hoping that more colleagues would use it. So the original AJL model has two lateral wings to use for the anterior suture. And here you see the how it looked, how you could see the transillumination, because as you can see, a fiber optic can be implanted behind the head of the buckle. And this is how I used to pass the suture around the lateral wings of the macular buckle, again in the anterior area. See, this is the light that can be inserted through behind the macular buckle. The instrument in the metal is is a loading device that I have designed to make the implantation easier. Again, even with this type of buckle, I thought that it was not so easy, because you cannot see the tip of the needle while you pass through. And again, it was difficult to position the buckle because it was moving a lot. I focus on different types of loading devices in order, always with the aim to improve the implantation. I will go quickly because I want to show you the new device, just to show you some history of everything that I have done in the past years. And then I asked AJL to create 4 wings, but that was not enough as well. And okay, and this is the one more model of loading device, different models of the buckle. So in the end, the one that you see on the right bottom is what I've been using since last year, and this is working very well. This is easy enough, and this is what I'm using right now. So as you see, instead of wings, it has 4 holes in the lateral arm. Still, you can implant a fiber optic for the transillumination, and the loading device makes it very easy. I'm also trying to figure out and tell you where to suture the buckle in order to standardize the technique. I started by creating a nomogram using the same buckle to tell you exactly at which distance from the limbus to place the suture based on the axial length. So I've been spending a lot of time figuring out this nomogram. But then now I think it's even better to propose you to have a customized buckle, and AJL basically will offer you buckles of different lengths based on the axial length of the eye, in order to be able to always place the suture at the same distance from the limbus. 11, 12 millimeters from the limbus is the easiest one because it's very well exposed, and it will not, it will be much easier and much, let's say, open to extrusion or other complications. The light for the transillumination is very useful, but I can tell you is not necessary. You also can do without. The loading device is useful, but you can do without. Isolating the muscles is very useful, but it's not totally necessary. And now I have switched the check of the location of the buckle from a panoramic viewing system to a contact lens. I think it's much easier, and I will show you how the surgery is done now. This is almost real time. It's as you see, let me stop and go back. I have isolated the temporal muscle and the superior muscle, and this is the superotemporal quadrant. I am standing in the superotemporal position to face directly the quadrant. I measure 11 millimeters from the limbus. I place the first suture. In this case, I have used the light. And as you can see, the light is connected to the buckle by a silicone sleeve. Then I insert the loading device, and then I insert the buckle. It goes inside fairly easy. And then the suture is passed through the anterior hole. I suture the hole on the other side, and then see, with the loading device basically makes it easier to keep it steady. And at that point, you can check the transillumination with the loading device. It's easy, to move the buckle and see exactly where it is. If it is under the macula, then the surgery is over, basically. It's done. It's a 20-minute surgery. This is another example of surgery combined with vitrectomy. In the same way, I pass the suture, insert the buckle, I place the second suture, I place the contact lens and check the macula. In this case, I had the macular hole to close, so I am creating an ILM flap. I can check it also with intraoperative OCT, but you can do without. And then I made a fluid exchange, and the surgery was over in less than 1 hour. You can do it even without light. So here I do all the surgeries in local anesthesia subtenon because I don't want to perforate. General anesthesia is not necessary. I open the conjunctiva in the inferotemporal and supraonasal quadrant, and I isolate the muscle. So here I measure the correct distance from the limbus. It's in between the two muscles. And then I place the suture. You can also implant the buckle first and then place the suture. See, I don't use any light here, only the loading device. I insert the buckle. I place the suture through the hole and close the first one. I think it's advisable to place the least amount of suture possible through the sclera because it's very thin. We want to preserve it. So usually what I do, I place only one, and then I check the position of the buckle. And if I'm happy, see, because through the flat lens, I discovered that you can see the macula even without any light. You move the buckle and you see the indentation. I also have the intraoperative OCT, but you can do without. And then if you're not happy with the, like in this case, I thought it was too close to the optic nerve, so I moved it anteriorly 1 millimeter compared to the initial suture. I placed the suture again, and then basically the surgery was over. I did another check with the contact lens, and then I placed the second suture, and the surgery was over. Okay, so I checked through the lens. I was happy, and so I decided to stop the surgery and just close the conjunctiva. You can see under the OCT the confirmation of the good position of the buckle. Closing the conjunctiva well is very important. It's easy. You see, to remove the loading device, you basically hold the buckle with the forceps, you remove the device. It's not necessary to remove the silicone sleeve that you use for the light. If you had used the light or to hold the buckle, you can leave it there. You remove the suture of the muscles, and then you close the conjunctiva. You have to be very careful to place a good amount of tenon and conjunctiva over the buckle. I try to avoid having the wound in the conjunctiva exactly over the buckle. I usually place it laterally, as you can see here, and then I close. So someone always asks me what to do if the sclera is very thin. In this case, I want to show you that I open, and after isolating the muscles, I found out that I had some blue sclera exactly where I supposed to place the buckle. So I did not feel comfortable in placing the buckle with that sclera. So what I did, I placed some tuto patch to reinforce the sclera. I sutured the tuto patch close to the insertion of the muscles. And then I want to show you the insertion of the buckle. It's easy again, even if the tuto patch is there. And so you can proceed as I have shown before. All right. Also, I've always asked what in case of choroidal hemorrhage. Well, I have realized that if we don't change the IOP too much, is much better. So I used to make paracentesis. Now I don't do anymore. No paracentesis, no sclerotomies. If you don't have to do vitrectomy, just the buccal. Basically, you don't open the eye, you just isolate, keep the IOP steady, check the pressure, systemic pressure, it should be steady as well, and avoid excessive in and out. As you can see, I implant the buccal, I just adjust the suture, but I tend not to remove the buccal and place it back again in order not to traumatize the scleral eye wall. So if you do so, I haven't had choroidal hemorrhage. Actually, I had very few. And if you have a mild hemorrhage, you don't have to stop. You can move forward. As in this case, I still used to make paracentesis. And this was a combined surgery. And I want to show you that I had some choroidal detachment in the peripheral area. But even that, okay, here you don't see it very well, but there was some choroidal. Probably you will see it better in the next. Let me show you. If it is only temporal and peripheral, there is no need to stop your surgery. You can move forward and finish it. Okay. See, unfortunately, the video is not so clear, but there is some choroidal detachment. And here in the 1 day post-op, you can see on top some choroidal, but that doesn't stop the surgery. So these are the complications that I observed in time. Decentration. I think decentration is my fault, is our fault, and it was also due to the fact that I'm improving the technique as I'm working. And I will show you what to do. 10% extrusion, but that happened when I used to use the sponge and the titanium. With the NPB in the last 3 years only, I haven't had that problem. Probably because it's a different material, and second, because I always try to implant around 10 to 12 millimeters from the limbus. 7% diplopia, and I will speak about all of them. 5% limited hemorrhage, and I had 2 bad cases of severe choroidal detachment. Metamorphopsia, optic nerve trauma, ischemia in the choroid, macular atrophy. I listed them with a question mark because colleagues always ask about this, but I have not noticed. So if you have a mild decentration, you don't need to do anything. Let's see this example. This is pre-op, stage 3B. This is post-op. You see 1 day, the buccal tip does not seem exactly under the fovea, but you have to imagine that the buccal diameter is much larger than that. And I observed that 1 month later, it looks mildly decentered, but I'm already treating the macular detachment. So I didn't do anything. And 6 months, it looks almost resolved. So I decided not to treat. But if you have significant decentration, like in this case, pre-op and post-op, I thought it was too decentered and the patient lived very far away. So I take them back to surgery 1 day. At 1 day post-op, you have to redo. This is the decentered version. See, the star is the fovea, and in red, I highlighted the position of the buccal. And And so this is after recentration. It was perfect. And this is how it looked after recentration. So my message is, if you decide to redo and replace the suture, do it one day after. Or let's say if you operate in the morning, just check a few hours later. And if you have to redo it, do it immediately. It's much, much easier. And how to avoid significant decentration. You know, I thought that the paracentesis and lowering the IOP had something to do with decentration. So if you lower the IOP before centering the buccal, then one day later, when the IOP rebuilds, you can have decentration. So when I stopped doing sclerotomies and paracentesis, I stopped having decentration. So I think that avoiding the changing IOP before inserting the buccal and checking the good position of the fovea intraoperatively. So I have the intraoperative OCT, but you can use maybe a sketch or a photo of the fovea and have marking and landmarks that you can recognize through your lens, and also transillumination. So if you use these tips, you will do fine. As I said, suprachoroidal hemorrhage, if you have a mild peripheral choroidal detachment, don't worry, just finish your surgery and it will go away. Like in this case, you see on top, it resolved spontaneously. And massive suprachoroidal hemorrhage, if we avoid the changing IOP and check the systemic pressure and avoid manipulation, you will avoid suprachoroidal hemorrhage. And if you think about it, you can have suprachoroidal hemorrhage even with vitrectomy. So these eyes are very delicate anyhow, but if you follow this procedure, you won't have. So what about diplopia? Vertical and horizontal diplopia. Well, when I used to implant a big macular buccal, I had higher risk of diplopia. Even with this buccal, you might have. So, of course, you have to treat it as you treat every type of diplopia. I also want to tell you that I have developed prismatic soft contact lenses that takes care of mild diplopia very, very well. We can speak about that separately. In severe cases, ideally, you have to remove the buccal, unfortunately. But that's very, very rare. How to avoid? I always advise the patient to move the eye in every direction since day one, a few minutes in different parts of the day, especially for the first week, because we want to avoid the fibrotic encapsulation around the muscles that might limit the movement of the eye. So advise your patient to keep the eye moving. Extrusion, I already told you that I used to see extrusion, but now I don't see extrusion. I think that the distance from the limbus is very important to avoid extrusion. And probably also the material that we use might be important. Sponges extrude much more than solid silicone. If you really have to remove the buccal for extrusion, which usually happens like after 6 months. Anyhow, if you have to remove the buccal, I suggest to wait at least 6 months, because if you remove the buccal before 6 months, MTM will relapse. If you remove the buccal after 6 months, then the effect of the buccal will remain, because you will have a fibrotic capsule that surrounds the buccal, and you can open the capsule and remove the buccal. In fact, I have designed this NPB with the lateral arm as large as the head in order to facilitate the removal as well as the implant. What about metamorphopsia? The buccal itself does not induce distortion or metamorphopsia. If you have metamorphopsia, it is because you have problems in the fovea. In fact, in stage A, there is no metamorphopsia. You can have it in stage B when the lamellar hole is very deep. You can have it in stage C for the full thickness macular hole, even if you close it, depends on how you close it. Does the buccal-induced optic nerve damage? I used to run MRI in every case. Now I don't, because if you stay away from the optic nerve, you will not have any trauma to the optic nerve. Do the visual field as I do, you will not see any change in the visual field. I used to run fluorescein angiography and ICG to study choroidal ischemia. The buccal does not induce choroidal ischemia. In fact, in some cases, you can look at the choroid. This is from pre-op to 1 day post-op. You see an increase in the choroidal thickness after buccal implantation. This is a few months afterward. So no ischemia. What about atrophy? I was asked about atrophy so many times. I decided to do a study on it. This is a publication that Carlos Mateo did on macular buccal atrophy. And he's telling you now not to implant the buccal because it induces atrophy. So I've been studying this topic very, very well. If you follow from A to B, C, D, E, this is not atrophic changes induced by the buccal. This is the natural history, the natural progression of atrophy in these eyes. As Kyoko no Matsui said, you can have more than 60% progression of atrophy in years as a natural process in these eyes. So I have done a study of patient operated with the buccal with a very long follow-up, and I have studied the progression of atrophy in the operated eye and in the contralateral eye. I have used the same parameters to study atrophy as Kyoko no Matsui did, studying if the atrophy was induced in the buccal area, in the surroundings, or if I had an enlargement of atrophy close to the buccal. And this is my case series, 116 eyes, where 71 were patient operated, 70 were operated with the buccal, and 46 were the contralateral eye. And basically the results are that there is no buccal-related atrophy. You can see some examples here of a very long follow-up with no atrophy close to the buccal. This is another example. On the left, a buccal eye. On the right, the contralateral pars plana vitrectomy eye. Again, other examples. So in conclusion, basically, I can tell you that the complications are rare and much more manageable than the complication you see with the pars plana vitrectomy.